Okay, so we have Aisha with us and Mona, and we have Samra and Savi.
Assalamualaikum.
Alaikum assalam. How are you? Okay, we have Daniel as well. Oops. Where are we going? Okay, so we have few people. I think we can start. Okay, so before we start, the people who have joined in, thank you first of all for joining our session. And can you briefly just introduce yourself? Yeah, come on. Aisha, Daniel, Dr. Najma, Mona, and who else is here? Rudena, Samra, Savi, Varda. Nobody want to introduce themselves?
Okay, madam, I just want to introduce myself. I'm Dr. Samra.
Yes, Samra, thank you.
I am Dr. Samra. I am working as a consultant obs and gynae in hospital in one of the tertiary care hospital, Karachi. And I did my MBBS from Sindh Medical College of Karachi, and then I am trained like fellow of College of Physicians and Surgeons, Pakistan. Okay. What
So
else?
Samra, are you trying to relocate? So you are going for this exam?
Yes, ma'am, inshallah.
Oh, okay. Chalo, good luck to you. Okay.
Thank you.
All right. So, okay, so I'm okay, Varda, Roshna, can't change name. Okay, it's okay. So you're Roshna, not Daniel. Okay, I'll remember that. Okay, so I don't know how many of you have already, appeared for the exam before, but just to give you a brief idea about the OSCE, for those who hasn't sat for the exam, that the OSCE has one long case, sorry, and 7 stations, OSCE stations. Actually, there will be 8, but 1 is a resting station. The long case, it's your luck. It can be either gynae or it can be obstetrics, which is a 25 minutes long case where you are supposed to take history from a simulated patient and perform an examination on a mannequin, and then do the case-based discussion with the 2 examiners who are sitting and observing you throughout 25 minutes. This is about the long case. And then you have 7 OSCE stations. The OSCE stations, 6 of them will be the case-based discussions. You will be sitting with the examiner. Only 1 station is a communication station where the simulated patient is there and the examiner is there. So examiner doesn't speak in that station, only the patient continues to talk. So this is about, a rough idea of the OSCE exam. So as you know, today's topic for us is assessment and management of stress, urinary incontinence in women. It is the new guideline which came in 2023, not very new now. And RCPI, they always stick to anything they have produced themselves. So whatever new guidelines came in 2023, make sure that you have read them properly and you speak from them. The answers should be from them, not from any GTG guideline or any other resources. If there is something not available from the RCPI website, then you can, of course, refer to RCOG and EPCOG or whatever. Okay, but it should be reliable. And if you feel that you don't remember the RCPI guideline in something, so please quote your resource, because sometimes examiner, they get offended If the exam is in some other part of the world like UAE or Saudi, then of course the examiners are not from Ireland. For UAE, hardly 2 examiners will come from Ireland, remaining will be from here. So here, even if you quote RCOG and other resources, it's okay. But if you're talking in front of a RCPI person and you're saying, quoting other references, then they don't like it. Okay? So what I would like to do today is just we'll go through the guideline, and then I will request one of you to do a case-based discussion with me. Is that okay for you people? Just tell me, is it okay for you all?
Yes, ma'am.
All right. So, okay, Varda, no problem. Just try to listen to the session, and hopefully this is going to help you. Okay. So, anybody would like to tell me the definition of stress incontinence? I want this to be an interactive session, please. So come up and start talking.
Any involuntary loss of urine on any coughs or straining or any weightlifting?
Yeah,
Involuntary loss of urine.
Yeah, excellent. Why I'm asking you the definition, because the case-based discussion examiner, they will ask you the definition, okay? So you should know all the definitions which are mentioned in this guideline. So as the guideline says, that stress urinary incontinence is the involuntary leakage of the urine which occurs with increase in intra-abdominal pressure. That is while sneezing, coughing, laughing, in the absence of bladder contraction. So it is just the stress which leads to the leak. So it is called stress incontinence. So what is the common age of stress incontinence as per the guideline? It is 45 to 49 years. And of course, it has a very negative impact on your quality of life. That is why it is very important to know how to deal with stress incontinence and what are the possible measures that can be taken to help such women who suffer from stress incontinence. Okay? Yeah. So this is, the guideline. There are 3. If you go to the guideline website, you see that there is a quick summary, there is a patient summary, and there is a detailed guideline. So at least you should know the quick summary, the main points of that guideline, what they want you to do, the flow charts, of course, and then it's very important to read the patient information leaflet, like what is the patient-friendly plain summary guideline, because this is what is going to help you for your exam. If it comes as a patient-simulated task, like suppose it can come as a long case as well. So then these, how to talk with the patient with the stress incontinence, that guideline and that plain summary is going to help you. Okay? So how we diagnose stress incontinence? Anybody want to say?
Doctor, either clinically, patient comes in of incontinence, and then during the examinations, we'll find there is a genuine stress incontinence. Or if there is other feature and we are not confirmed, then we'll do by urodynamic study.
Yeah, you're very right. So first of all, of course, patient will give you a history, and then you will confirm your diagnosis upon your examination. So what examination do we do?
Valsalva maneuver. Just ask her to push or to cough, or Valsalva maneuver. Yeah, and this I want to examine her in semilateral positions, then we'll ask her to cough.
Yes. And what are the simple tests that we should do? Once the patient is complaining of stress incontinence, initial test?
Cough test. Valsalva.
Urine dipstick.
The cough test.
Okay, cough test you have done to confirm. Now you want to do some other tests. So what are the next tests?
Oh, I think we elevate the angle of the bladder. Yeah. We elevate the angle by the examination. We elevate the angle of the bladder during the examinations, and we'll ask her again to cough. If there is, let's confirm it's stress incontinence. I think that.
Okay, so now you confirm your stress incontinence. You want to rule out anything?
Urinary infection, UTI.
We can do muscle tone test.
Yes. Very good.
Muscle tone.
Muscle tone comes, that is for the physiotherapist. So you will do a simple urine analysis to exclude infection. And then after urine analysis, what are the other things?
I think we'll do ultrasounds as a sequence of investigation. We'll do ultrasound to check residual urine.
Exactly.
After excluding UTI, we should do urodynamics.
Urodynamics and then ultrasound residual urine, both things you can do.
Ma'am, we will go for urinary diary.
Urinary diary, it is, it is not that applicable. It is more applicable in overactive bladder. Okay. Or if the patient is coming to you for the first time, then you want to know the habit of her intake and when she leaks and what type of fluid is she taking, what time of the day is she taking. So that is, a little different from here. Okay?
Okay, ma'am.
All right. So I will just skip this part and let's come to the main summary. Yeah. Okay, so as we discussed earlier, that they strongly recommend detailed history, of course. What part of history are you interested in?
Doctor, we have three parts of the history. First, we assess? I mean, we should recognize. I mean, we should understand which types of incontinence she have, or she has other complaint like urinary tract infection, stress, or urge, or she has some voiding problem during history, and also will confirm the durations, and we try also to confirm the severity of her complaint, whether affected her life. Quality of life. And also we try to find the predisposing factor behind it. If she has any stress incontinence, what is the cause behind it for her stress incontinence?
Yeah, so what is the cause of stress incontinence? What are the common causes of stress incontinence?
Maybe increase intra-abdominal pressure. It could be obesity. It could be cough, chronic cough, like chest infections or whatever, asthma. It could be because of delivery, previous delivery. For female, usually we search for parity. There is any difficulty with her if she has vaginal delivery, and if there is any difficulty in delivery, size of the baby, there is chronic constipation. I mean, this is the predisposing factor behind it.
Yeah, exactly. Very good. So you have to know the obstetrics. So who was asking in the group that how we will know what history we should take, particularly in particular cases? So here it is, that once you are dealing with the patient who is coming with a urinary problem, obstetric history is very important. Okay, sometimes you will have a young female. They might bring you a young female, 32, 33 years of age, who is presenting to you with stress incontinence. Then there are few things you have to exclude in that patient. After taking obstetric history, you have to know the weight of the baby, the mode of the delivery, how was the postnatal period. And then, of course, it can be either just a prolapse or it can be a fistula. If it is an instrumental delivery, then it can be a fistula. So, history, obstetric history is very, very important in cases of urinary incontinence. Then what else is important? Constipation, anything which increases intra-abdominal pressure. What else can increase the intra-abdominal pressure?
Any mass, ma'am?
Yeah, any mass. What else?
Obesity.
Obesity, yes. What else?
Smoking.
Chronic cough, any COPD patients.
That is all correct. There is something else which is related to your work.
Heavy weightlifting, those who are doing involved in
Yeah,
occupations
exactly.
in weightlifting,
Nature of
maids.
job. Yes, very good. So nature of job is very important. Yes, Sunita, ascites can be secondary to something, some other medical problem. But of course, in this incontinence patient, you have to ask them what is her nature of work. So if the patient is working in a factory lifting heavy weights, so she has to change her job because that is one reason she might be incontinent. Okay, so these are the few things you have to put together that, okay, if you will not ask all these questions in the history, then it is very unlikely that you will pass that station. Okay. So we ask about the, first of all, patient's normal history, what she came with, her presenting complaint, then the history of presenting complaint, and then of course you start with the, if she's a patient in reproductive age, you ask about when was the last child born, is she on any contraception, when was the last period, how many children she has, what was the mode of the delivery, what any problem during delivery, any problem in the immediate postnatal period, and then any surgeries in the past. And of course, you have to exclude urinary tract infection in any case of stress incontinence, because that is very, very common that UTI leads to incontinence. Okay. Clear so far? Okay, so as per this guideline, after the history, you perform a clinical assessment where you do a pelvic and the vaginal examination. So we have already spoken about that you perform a cuff test. In the exam, as I said, there will be a mannequin. Of course, the mannequin will not have any incontinence, but they expect you to verbalize things. Once you are doing a speculum examination, why you are doing a speculum examination. So, you should know how to talk in front of the examiner that, okay, I'm putting this speculum, I will ask the patient to cough, and if I see any ball leaking, that means there is this is a stress incontinence because she leaks upon increase in the intra-abdominal pressure. So that mannequin, first you do a general physical examination. Of course, mostly if it is just a gynae case, the upper half of the mannequin is not there, the lower half is there. But still you need to explain to the examiner that what all you will see in a general physical examination. So you always start by, sterilizing or wearing gloves or putting a this hand sanitizer on your hand. Rub your hand because it's cold there. You have to pretend that things are like that. You are in Ireland. And always take permission of the patient. Just say, I would like to examine you in the presence of chaperone with your consent. Always ask the patient to pass urine before you perform an examination, especially abdominal examination. And then you start with the physical examination. Of course, even if the upper part of mannequin is not there, you have to perform abdominal examination. And then in the gynae case, they expect you to do a vaginal examination of the mannequin, a speculum examination, and they will give you a pap smear also. So if they want, you have to show them how to perform a pap smear, how to take a pap smear. Okay?
Dr. Uzma, sorry to interrupt you. Only stress incontinence, no need to ask the patient to pass urine. We'll examine her with whatever she has to check stress incontinence and then allow her to go to pass urine. Only this exam
in this case, yes, you are right. For stress incontinence, you want to see the incontinence. So if a bladder is empty, you won't see anything. That is very right. But otherwise, I'm saying whenever you're about to perform an examination, ask the patient to pass urine. Okay, just in this case, you will not ask because you want to exclude the incontinence. Okay.
Excuse me, doctor. As we are saying that we will not ask patient to pass urine before this examination, but there will be this probability there will be residual urine in bladder like that. There's not possibility that there will be still she will come with this stress urine incontinence even if she passes urine.
the thing is, residual urine you will only be able to see with the help of ultrasound. Right now we are doing examination, and if you want,
no, I'm asking that suppose patients pass urine, and if we are examining her for the presentation of this stress urinary incontinence. So patient, if we ask her to cough even after passing urine, if she is the case of stress urinary incontinence, still she will not. There will be some leak.
You see, it is plus minus. Not all patients with stress continence will have a residual void, right?
Okay.
Some might have, some might not have. So that is why if the history is suggestive of a mixed type of incontinence, then you have to, you don't ask the patient to pass urine before examination, because it won't be possible for you to see any leakage in patient who don't have a residual urine, right?
Okay.
So that is why for the purpose of exam, you have to say that, okay, in this particular case, I don't want her to pass urine because I want to exclude any leak upon cough test. Okay.
Okay. So we'll say in front of examiner like that, huh?
Yeah.
Because it is not mentioned in the guideline actually. So that's why I'm asking.
Yeah, not everything is mentioned in the guideline, but the examiner, they will start asking you, okay, you ask her to void, then what are you going to see now?
Okay.
Cough test will come negative because you told her to pass urine, but she's still a case of stress incontinence. So what next? So they will start pulling your legs then.
Dr. Uzma.
And also,
Okay, Shazia, continue. Oh, sorry.
Yeah, sorry. One more query. You said there's with UTI, there is link with stress incontinence. So what is the link, Dr. Uzma, this UTI with the stress incontinence? Because I expect this link from with the diffuser overactivity or with the other, but not expect with stress incontinence.
Yeah, the thing is urinary tract infection. What are the symptoms of urinary tract infection? You will have dysuria, you will have frequency, you might have pain in the lower abdomen, right?
Okay.
Okay. So sometimes this can also lead to incontinence. It is not stress incontinence, but UTI can, of course, if you are having again and again urgency frequency because of the dysuria or because of the infection, you might leak as well.
Okay, so it will not be stress incontinence then. It will be the urinary infection.
You just have to exclude UTI. I'm not saying because of UTI you will have stress incontinence. Any patient who's coming with a urinary problem, the first thing you will start with is to exclude an infection. So you always do a urine dipstick. This is the basic investigation. You see, we recommend basic investigation to include urine dipstick or microscopy.
Yeah, definitely we do. Yeah, we need to exclude mixed incontinence as well. So we do. Yeah. But I thought I misunderstood that it is linked with stress incontinence. That's why I'm asking. Thank you so much.
It is not linked, but this is basic investigation.
Yeah, thank you so much, Dr.
No problem. Yes, you were saying something?
Yeah, Doctor, I'm saying because Shazi, she asked about residual urine. Doctor, for residual urine, from practical point, you are not mentioned in the guideline. Because if it's a huge residual urine, so the patient is not suitable for surgery for stress incontinence. This is why I refer them to the urogyne, because I have one colleague who's urogynecologist. If there is residual urine, huge amount, more than what we have in gynae, not in, in obstetric, then this patient is not suitable for any surgical treatment for stress incontinence, because maybe she has headache, some voiding problem, or after surgery it will be worse. It will get more voiding problem. That's why they concentrated on residual urine after she's passing urine as a part of urogyne examination. That's the point. It was not mentioned in our guideline, but this is from practical point in urogynecologist. And sometimes you are right. In MRCPI, the examiner will ask more deep.
Yeah, you see, first of all, we have to understand that this MRCPI exam is just a specialty level. It is not super specialty. So don't talk of things which are beyond the scope of this exam, because you won't get any marks for it. They have a answer sheet with them where they expect you to answer certain things, okay? If you have the knowledge, it's good to have knowledge, but at least you should have that much knowledge which is required to pass the exam. Anything above that, it can be an added advantage, but it is not necessary because you are not giving a super specialty exam. Okay, it is not subspecialty exam, it is just a basic exam.
Yeah, you
So-
are right. Yeah, because sometimes we trap ourselves during, if we say something, maybe they ask, that's why. Sometimes they ask, doctor. I don't know, especially in MRCPI. It may be in
MRCPI, yeah, exactly. You are very right. MRCPI, sometimes the examiner is, especially the people who had experience of giving exam in Ireland, they found some examiners which started pulling legs because I'm sure that, of course, they started with some basic question, but the candidate might have, extra knowledge or something else in her mind. And then she started or he started answering something like that. And then the leg pulling started because I remember there was a case of PIH, a long case, and there were two examiners sitting, and there was a candidate who said that, examiner said, okay, you have answered everything about PIH. I want to ask you something about cervical CIN. And then CIN he started, and then he started why the dye takes this color, why the dye doesn't take that color, what is the problem, like to the histology level. So, I'm sure that there must be something which the candidate did, which irritated the examiner, and he went to that side of the part of exam.
correct.
So, try to stick to the topic and just to the level of specialty. Don't go to many details. Of course, you should know the basic treatment and what surgical options you have. What are the pros and cons of each surgical method? This is what is expected out of you. Nothing more than that. Okay? All right. So, do you do a urodynamic testing immediately or you wait?
For urogyne, if there is no other feature, like other feature of incontinence, or if there is failed surgery, we'll go. Otherwise, we can go for, if every examinations and what we have from a simple investigation will do, and it's confirmed that it's stress urinary incontinence, or it is genuine stress incontinence by clinical examination, then we, according to the criteria, patient parity, if she want to do more children, if she's willing for more delivery, vaginal delivery especially, or she is not complete her family, and such or she is, she agreed to the permanent method, probably will go for permanent method. Otherwise, we have two options, either medical or temporary method. So urodynamic after failed surgery, we can go to the urodynamic study.
Exactly. Yes, Sana, you are also very right. And yeah, we have to wait. We have to do the basic investigation and do the basic things. And then if they are not effective enough, then we have to proceed with the urodynamic testing. Okay. Especially if you are expecting surgical treatment, then of course you have to perform a urodynamic test. Okay, so what they say that we recommend that urodynamic testing is carried if the type of incontinence is unclear. If you don't know, even after examination, even after history, you don't know what is the problem. Is it mixed especially in mixed incontinence, you don't know what is, is it overactive bladder which is causing stress incontinence, or it is just a stress incontinence, then of course you have to perform a urodynamic study. Okay, so here examiner will ask you that why you will perform a urodynamic study. So now you have the answer that once either you know that the option is going to be a surgical one. So yes, you can perform a urodynamic study, or after your basic investigation and basic measures they fail, you go for a urodynamic study. Or once you are not clear about the type of incontinence, then of course you have to go for a urodynamic study. But the patient already had a procedure done before for the incontinence, then you have to perform this study. Clear so far?
Excuse me, Dr. Uzma. In the guideline, it is mentioned that it is recommended prior to all surgical procedures for stress urinary incontinence. It means that if we are proceeding to surgery, then we will definitely do urodynamic testing.
Yeah, of course, surgery, if you are planning surgery, because you don't start with the surgery, right? If it is a clear-cut indication that only surgery will help, then that you have to go for urodynamics first. If you are still, it is just the beginning, then you start with the conservative measures, right? The pelvic, we will come to the treatment part. Okay.
Okay. So first conservative, and then before surgery, we will go for urodynamic, like that.
Yes, before you do a surgery, you have to perform a urodynamic study.
Thanks.
Welcome. Okay. So what else? So referral for additional investigation may be indicated. So then what you have to do? Oh my God. Wait, huh? So what additional investigations we would like to do apart from urodynamics?
Doctor will do random blood sugar just to check if
Okay.
she's diabetic.
You can do a random blood sugar, yeah, to exclude diabetes. And what else? Sometimes if you are seeing hematuria, what you want to do?
Cystoscopy.
Yeah, cystoscopy. Although it is not indicated as a part of evaluation, but sometimes you need to do additional tests. So the additional test means if you are seeing hematuria, then you are concerned about some minor lesions in the bladder. So you, of course, you have to go for a cystoscopy. Okay. It is not, again, it is not a part of evaluation, but this is an additional investigation to exclude something else. Okay. For him, yeah, cystoscopy. Yes, Sunita, very good. Okay. So as we said that neither cystoscopy nor imaging are indicated as part of the evaluation. Like imaging also, you want to check for any post-residual void. So of course, that is with the scan. And you have to explain to the patient all the available options of the treatment, including risk and benefit of each procedure or option. Okay, this is very important in the exam. Whatever you are saying, especially the surgical options, please remember their pros and cons, because the marks are there. Okay, so if the women with stress urinary incontinence, or where it is a mixed incontinence, but the stress part is more predominant, and you are considering surgery for that woman, then of course you should offer all the options, like no further treatment. That is also always an option. Okay, that sometimes patient, they don't want to do anything. But pelvic floor muscle exercises, it should be supervised, and the non-surgical options like pessary or then the surgical option. Okay, clear? So this part we have already discussed, that all the women undergoing surgery should be informed on all surgical options available for them and counseled about their risk and benefits, and especially those who are going for a mid-urethral sling, what type of mesh they will use, or a mesh procedure, because in RCOG they don't use a mesh, but you only use a mesh once. Tell me when you use a mesh. Hello? When you use a mesh for surgical, or as a surgical option? Anybody?
TVT and TOT, doctor?
I cannot hear, sorry. Speak louder a little, please. Okay, no problem. We use a mesh only once we see that there is no other procedure possible. Yeah, TVT or mesh, Why we use this one? Because in RCOG they said not to use it, but we use the tape or the mesh once there is no other option available, or you have debriefed the patient fully about the possible risk of this tape or the mesh. Okay, clear? All right. So what else are they saying? That they recommend that the details of surgical procedures like a mesh or a bulking agent or implant are registered with this HPRA and recorded in the National Register of the Pelvic Floor Implants. Okay, so this is the body where it should be, whatever you are using, it should be a registered one. And it should be done by appropriately trained surgeon who are doing these surgeries regularly and who work with the MDT. Okay, so not anyone and everyone can go and do this procedure. And we suggest that these implants should only be considered after all options for the conservative and non-mesh surgeries have been discussed. Okay, so this is what I want you even. So RCPI is also of the same point of view that mesh implant should only be used either once all the other measures have failed, or the patient, this is the only option which can be applied to certain patients. Okay. And what this suggests that single incision slings and TVT should not be used. They suggest retropubic slings for uncomplicated SUI, and transobturated tapes should only be considered with high risk of bowel or other injuries, which is possible with the retropubic route. So is it clear for you people, this 15th recommendation?
Dr. Asuri, can you tell more about the tape, the prerequisite for the tape?
Yeah, so what they are saying that implant surgical mesh, first of all, it should be used only once other measures have been discussed or used. Okay, and if you are using a mesh, they don't want you, they suggest that don't use the single incision sling or a TVT obturator. Okay, what they want is to use a retropubic sling. Of course, they don't expect you to explain how to put a retropubic sling, but you should know which sling to use initially. And what they are saying that this transobturator tape, when it should be used, once there is a possibility that if you put this retropubic sling, there is a risk of any bowel or other injury, bowel damage or any other injury with the retropubic root. Okay, so that is why
Thank you.
retropubic root. Got it?
Yes. Only the nimbus. We know that retropubic is the root.
Yeah, this is what they want, that retropubic is the root, but only other root should be used where you are expecting that this root might cause injury to the patient. Okay?
Okay.
All right. So now this is again, we are back to the history, that what are the questions you have to ask in the history once you are doing a patient with a stress continence or any incontinence. Okay, so what question is, you ask the patient to describe her incontinence episode. So in stress incontinence, the patient will have loss while coughing, sneezing, or doing any activity. And other incontinence, there is sudden urgency with inability to reach to the toilet. So that is urge incontinence. Okay. In stress incontinence, the precipitating factors can be cough, physical exercise, any strain, like any abdominal masses. We have discussed this before. While in other incontinence, it can be just a full bladder or sensory triggers like running water. If you hear water falling, you might have sudden urge to pass urine. And then while you are rushing towards washroom, you cannot control yourself. In stress incontinence, there is no increase in frequency, while of course in other overactive bladder or urge incontinence, there is always increase in frequency. Stress incontinence, nocturia is normally less than 1 because it is not related to anything else, not overactive bladder. But in incontinence, it can be, there is nocturia is mostly more than stress incontinence. And for the stress incontinence, of course, the volume of urine loss is less. So pad can be sufficient. But while in urge incontinence, you may have large amount of leak. So of course it can, soak your clothes and it can spoil your legs and all. So this is the algorithm which they expect you to know by heart. So as we have already discussed before, first part is our history. And then if there is incontinence on physical activity, then there's always some general measures. We will come to the general measures later. And then incontinence, which is with mixed symptoms, or there's incontinence with frequency and urgency. So physical activity is our stress incontinence, right? Mixed symptoms, they can be a mixed element of stress and overactive bladder. Or if you see there is no incontinence, there's just overactive bladder and there is urgency, frequency, it can be associated with incontinence. Maybe it is not associated. So that is an overactive bladder. Okay. All right. Then we have discussed this part also again, that clinical assessment is our general assessment. Then urinary symptom, as who said this urinary bladder diary, that is a questionnaire, that is if patient is coming at the GP level. Okay. So in your exam, the patient has already been to the GP and now the patient is coming to you because now you are as a specialty level. Okay. So the bladder diary, if the patient is coming for the first time to a doctor, of course, you speak about the bladder diary. Okay, then how much this problem is affecting her quality of life. As we said earlier, you perform a physical examination, which includes a general physical examination, abdominal, pelvic, and perineal examination. You do a cough test to demonstrate stress incontinence if appropriate. You do a urine analysis, and if you see any element of infection, you proceed for the culture. And if the patient is a postmenopausal woman, or even a breastfeeding, lactating mother, they are also, they have reduced estrogen. So you have to assess the pelvic muscles for any lack of estrogen. Like if you see any atrophy of the perineal muscles, so you might prescribe them with the estrogen cream. Then you have to assess the tone of the pelvic floor muscle, and you have to check for any post-void residual urine. Okay? Clear so far? Anybody would like to just repeat how you will start with the patient? Come on, it is in front of you. You can even read it and say it. Unless you start speaking in the exam, you will not be able to make it, darling. So please start speaking.
First, we
are
have to take
just
the
a
history.
session. Yeah, good.
First, we have to take the history. We have to see the incontinence on physical activity. Either it's incontinence with mixed symptoms or incontinence frequency with urgency. Then we have to do clinical assessment, journal assessment, urine symptoms assessment, bladder diary, questionnaire, assess quality of life, desire for treatment. And we have to do physical examination, abdomen, pelvic, perineal, cough test also to demonstrate stress incontinence if appropriate. We have to do urine analysis, either urine culture or not, if infected lady, treat, reassess if appropriate, assess estrogen status and treat as appropriate. Estrogen status for vaginal atrophy, ma'am?
Yeah.
Okay. Assess pelvic floor muscle function test and assess post-void residual urine.
Yeah, very good. Okay. So why this thing is in the red? Why you think it is in red?
In red, because it's complicated incontinence and we have to check recurrent incontinence and also incontinence associated with pain, hematuria.
Your voice is gone. Hello.
Radical pelvic surgery history. suspected fistula. I mean VVF, ma'am.
Yeah, if you are suspecting of vesicovaginal fistula or any vesicorectal fistula, then of course, like this, why this is in red, my question was this, that because it is a complicated things. So if you are seeing if this incontinence is associated with lot of pain, which is, significant type of pain, because if a simple stress incontinence, which is not with the infection, it will not be associated with any pain. But if the patient is saying there is pain, there is hematuria, so you start to think in, other things, like maybe there is some malignancy going on. So that is why these things are in red, that if there is significant pain, if there is recurrent incontinence, or if there is hematuria, if there is recurrent infection, or there is significant voiding symptoms patient is having, or there is a past history of any irradiation or pelvic surgery, or you're suspecting a fistula, so of course these are the high alert signs. So you have to refer them to the tertiary centers. Okay, this is why it is. You don't deal with them, you refer to the tertiary center or the higher next level. Okay, so now coming back to our basic stress continence. So now either you have three type of diagnosis, right? After your initial assessment, either it can be a stress incontinence, which is of course due to sphincter incompetence. It can be a mixed incontinence. So you have to, in mixed incontinence, what you have to do, you have to treat the symptom which is bothering the patient the most. Okay, because sometimes patient is more irritated with the sudden rushing to the washroom and then being incontinent, or then patient having little leak while coughing or sneezing. So if you suppose you have treated the stress part of this incontinence, but the urge incontinence is still there, patient will still be an unhappy patient. Okay, so always treat the symptom which is bothering her the most in a mixed incontinence scenario. Okay, then any overactive bladder with or without urgency or incontinence, this is a detrusor activity, so you manage that one accordingly. So as we know that there is always a lifestyle intervention, there's pelvic floor muscle exercises for the stress incontinence, and it also works for other incontinence. Okay, then bladder training for an overactive bladder, and then the medical treatment, which is antimuscarinic or beta-3 agonist for the overactive bladder, and then we go to the surgery. Okay, if our part, you see it's still here. So lifestyle modification, PFMTs, bladder training if overactive bladder, then medical treatment of overactive bladder, and if your patient wants to go for a medical treatment of SUI, you can give her duloxetine. If all this fails, then they go for a specialized management. Specialized management means surgical management, which is not for us. So you have to know what they will do, but you just have to know the basic names. If you're proposing any surgery, as I said earlier, pros and cons of each surgery. Okay, clear so far?
Yeah.
Okay, so let's come to this one. So this is either there is no treatment. Always remember this no treatment option. Okay, whenever you are answering the examiner, that there is always a thing where there is no treatment. Sometimes there is no treatment possible, maybe because of the old age or other reasons that there is no treatment possible. Then there are non-surgical treatment and there is surgical treatment. So non-surgical treatment is pelvic floor muscle exercises. So what should the patient, how many contractions per day they have to do? For how long?
6.
No.
3.
Anybody? No.
3. Excuse me, 8 contractions,
Yes.
3 times per day for 3 months.
Yeah.
Exactly.
And it should be under supervised. It should be supervised with the physiotherapist.
Exactly.
Yeah.
Very good. So it should be 8 contractions, 3 times daily for minimum of 3 months. Better to be supervised. If the patient doesn't want it to be supervised initially, then they can do. But if they find no benefit in that, then the best is to go with the supervised exercises. Okay. Yeah, Sunita, you're right. Okay. So then what is the other non-surgical treatment is a pessary, okay, or an incontinence device like a pad. They can use that one. Then there is duloxetine that can be used for stress incontinence. Patients, as I said earlier, either postmenopausal women or women who are lactating and complaining of incontinence, always bear in mind that there is lack of estrogen in such patients. So estrogen cream will help them, okay? So local estrogen, and of course, obesity might be one of the causes of incontinence. So you have to go for a weight loss. Okay. So remember all these things once you are with the examiner, that you start with the PFMT or a continent pessary or some device, incontinent device, medical treatment, local estrogens, and weight loss. Then you have the surgical options. So surgical options, you have bulking agent, which you put in the urethra. So what is the problem with the bulking agent? Anybody want to say? Nobody want to tell me?
They're permanently injected like that.
No. There's nothing permanent. Bulking agent you
Okay.
have to take a
Stenosis?
No, it is not stenosis. Actually, what happens is that once you, first of all, yearly, 6 monthly, you have to do the bulking agents, okay? And then all these procedures, they can lead to retention of urine. So there will be the urine, you have to teach such patients about this one, self-catheterization, okay? So the problem with the bulking agent is that patient might not be able to pass urine at all. So you have to teach them how to do intermittent self-catheterization. So the patient will tell that I came with problem with stress and incontinence. Now I'm not able to pass urine at all. So there's retention of urine. So that's what I'm telling you, that each treatment you have to inform her about the pros and cons of the treatment. Okay.
So, ma'am, bulking agent causes the retention of urine.
It can cause retention of urine. So that is why you have to teach the patient first intermittent self-catheterization before embarking on any treatment. Okay.
Okay.
All right. Then you have surgeries. Surgeries can be a mid-urethral sling, that is a mesh, or a colposus suspension, or a pubovaginal slings, retropubic tape, or a transobturator tape. This, as we said earlier, transobturator has specific indications. So sling procedure, what you do in a sling procedure? Nobody knows.
Elevate the angle using natural material, allograft, from the body, and elevate the angle of the urethra.
The graft can be either an allograft or a synthetic graft. There are 3 types of grafts available. So you put that graft to correct the angle of the urethra so that there is no incontinence. Okay. And what is the other name for the colposus suspension? What procedure we call it?
Perch suspension.
Perch. Yeah. Very good. Yes. Very good. Okay, so what they expect from you is to know the names of these procedures, okay? You don't have to explain how to perform the procedure because this is beyond your level, and just you have to know the names of these procedures. Okay, so as I said earlier,
what is the other name? Birch
colposus suspension. Yeah, this colposus suspension, it is BURSCH.
CH.
Okay?
Yeah.
BURCH, huh? Okay. So, what else they are telling you? What are the risks of these surgeries? Anybody want to comment on the risk of these surgeries?
Recurrent.
Okay, start with the common things. What can happen with any surgery?
infection,
Yes.
bleeding in urine,
Yes, very good. Yes.
pain,
Yeah. So these are the three common things which can happen after any procedure, right? Bleeding, infection, pain, right? So always start with the common things and then come to the particular, what can happen with that particular procedure. Okay, so what we said earlier, what can happen? Failure of the procedure, patient might still be having
recurrence,
incontinence, right?
yeah,
What else?
recurrence,
Recurrence, yes. And if the patient had a mixed incontinence, as we discussed earlier, that you treated the stress part of that incontinence, but the patient is having a mixed incontinence, so other part is still there. So the patient will be happy or unhappy?
unhappy,
Unhappy, of course. So this urgency incontinence is still there, or at least overactive bladder is still there. Okay. Sometimes this part of the symptom, it gets worsened after surgery. Okay. So the patient counseling is very, very important before you embark on any surgical measures for the treatment. Then you can have pain during sex, especially with the tape. Sorry, with the tapes. Okay, and then there can be pain which is going to the groin area. Okay, clear?
ma'am, pain with which procedure? Going to groin area?
Pain is mostly with this tape procedure which radiates to the groin area.
Okay.
Okay, so I want to, where is that? Yeah. Okay, so you can see here the surgical approaches. Let's go through this slide. Okay, so what we have, the choice of the stress urinary incontinence treatment. As we said earlier, that you have to discuss with the patient the risk and benefit of each procedure, okay? And refer women to an alternative surgeon if they choose procedure that is not available with you, okay? Then if conservative management has failed, then you either perform a tape or an open corpus suspension or an autologous rectus facial sling. So as I said, there are different type of slings available or mesh available. So synthetic mid-urethral tape, once you are offering a synthetic mid-urethral tape procedure, you should use procedures and devices which are a high quality, evidence-based in efficacy and safety. And always use a device which you have been trained for, and use a device which is manufactured from type 1 macroporous polypropylene tape. So please, these are case-based discussions. So remember these things, what type of tape you will use of which material. So this type 1 macroporous polypropylene tape is important. Remember that, okay? And once you're using a tape, always use a colored one because of the visibility issues for ease of insertion and ease of revision. Revision means you might need to remove it because patient is having a lot of pain or bleeding or something, so you might have to remove. So that is why you should use a high colored tape which is visible to the eyes. Okay, and use top-down reprotuberant approach only as part of the clinic. This is okay, forget about it. Then this is either you go for an open corpus suspension or an autologous rectus facial sling. So when you will see the patient after the initial procedure? Yes, girls? 6 months, okay? Oops, where it went. So first is initial part of the post-surgery, you will see the patient, and then for the incontinence, it should be after 6 months of the continence surgery. Then if this part failed, then secondary stress urinary incontinence procedures, which are those women whose primary surgical procedures has failed and they are returning to you. So you have to refer them to the tertiary care centers with the MDT approach, and then you offer them this other things like if a woman chooses not to have any further, like women can say that, okay, I don't want to do any further surgery. So then what you do to these patients, you offer her advice about management of the urinary symptoms, explain that if she changes her mind, she can always come back to you and you can reconsider, and she can reconsider other treatment options. Then what are the other alternative treatment options? That is intramural bulking agent. You can use silicone, carbon-coated zirconium, or hyaluronic and dextran copopolymers for the management of the stress incontinence. And they should be aware that, of course, it can lead to infection. It can, the efficacy of this injections, it will become less with passage of time, and you might have to repeat the injections, okay? Then there is another option of artificial urinary sphincter. This is only done once all these above measures, they have failed, okay? And what they say, do not offer a laparoscopic colposuspension as a routine procedure, so they prefer open colposuspension, okay? And only an experienced laparoscopic surgeon working in a multidisciplinary team with expertise in assessment and treatment of the urinary incontinence should perform these procedures. So anterior colporrhaphy, needle suspensions, paravaginal defect repair, and Marshall-MRCPI Kranz procedure are not treatment of urinary stress incontinence. Okay, so please remember this, that people will say that, okay, I will perform an anterior vaginal repair for the stress incontinence, it is going to help. No, it is not going to help. Okay, it might be a bulge which is bothering the patient, so that part of the thing will go, but you have to do correction of the urethral angle. Clear so far?
Yeah.
This Roshna, this is from NHS. Okay, I wanted to bring something from NHS also for you. So this is from NHS, okay? Oh, where it went. And this is based on the NICE intervention procedure guidance, okay? No problem, Roshna. Okay, so again, we'll just quickly go. So this is the resource from where I have taken this flowchart. This is St. Mary Managed Clinical Service, Manchester NHS Foundation Service. Just I wanted you people to have, you know, just in one flash, you will just revise everything. So that is why this chart is here. Although we will stick to our guideline from RCPI, but just for you people to remember things in a, you know, once you're going for a revision at the end of the exam, you cannot read all the guidelines. So you should have some flow charts with you. That's why the flow charts are here. Okay, so we already discussed, just to have a quick revision, that you have a history. In history, you start with the urinary history, which is frequency, nocturia, urgency, incontinence. Is incontinence, you have to ask for symptoms like stress, urge, or voiding problems. You ask for any prolapse symptoms, bowel symptoms, sexual dysfunction. You ask about obstetric history, gynae history, surgical history, past medical history, any comorbidities, BMI, any neurological problems, which is very, very important. You have to assess the neurological status of the patient, and any underlying constipation, or patient has been treated for any abdominal problems. Then examination, as we said earlier, abdominal examination is speculum and bimanual examination, and you have to assess for any prolapse. Then investigation, you always start with the urine analysis, and if it is showing infection, you go for a culture as well, and 3-day bladder diary, that is at the initial part, okay? And then if there's UTI, of course, you treat the UTI. If there's constipation, you treat the constipation, and then you assess for the bladder diary. With the bladder diary, you will have an idea that the patient has what type of incontinence. You need lifestyle modification, fluid management, or there is a element of some stress incontinence. So with the stress incontinence, as we said earlier, you start with the pelvic floor muscle exercises, that is for 3 months, and you can consider vaginal estrogens if the patient is either postmenopausal or a lactating woman. Okay. Then urge incontinence, if that is the dominant part, so always lifestyle modification is always there, including the weight loss, fluid management. And the patients with overactive bladder, you tell them not to have a lot of caffeine because that irritates the bladder. And then bladder retraining is required. Pelvic floor muscle exercise, of course, it helps here as well. And vaginal estrogen also will work if the patient is postmenopausal. When you refer the patient to secondary care, where you see either there's a mass or there's a fistula, there's a symptomatic prolapse which with incontinence. Okay, so this is not for you. And there is voiding difficulty plus incontinence. So any complicated case, you have to refer for the secondary care of or you see there is a previous failed surgery, there is recurrent incontinence, or there is neurological problem, or there's a lot of pain or hematuria. Of course, you have to refer such patients to the secondary care. So when you review them after the conservative management, 3 months, okay? If 3 months they are still having symptoms, of course, you refer them for further surgical measures on other secondary care level. Clear so far? I think this is very easy flow chart to remember how to go about the any type of incontinence.
Yeah.
Right or wrong?
Beautiful. Yeah, also beautiful job.
Yeah. Okay, so here again, this is also, you know, a quick summary of what we just discussed. I don't want to repeat all these things again. We have already repeated it multiple times. Okay, so this is just for you people, how to treat overactive bladder or mixed incontinence. This is also, you know, all the treatment chart and what is the dose and what is the preferred method route. So just to go through these, we will keep them for you people. Okay, now it's the time for this one. Let's go for the station. Who want to do the station with me? It will be just 10 minutes task, and you people are already experts in, you know, dealing with the station. So please let me know. Come on, girls, it's just a session. Hello, where is everyone? Written course, Sana?
Yeah. Our written course is also running now.
Yeah. But I'm doing the OSCEs. Written course is taken care by other 2 doctors, I think.
Yeah.
Okay. So anybody want to volunteer for this task? Or everybody want to stay quiet?
I just want to read because I am very new. I am doing theory.
Okay. So anybody else? She is doing theory. Who is going for OSCE? We have people, right? We are very intelligent people who already know everything. So come up, girls. So many. Dr. Gulshan, JM, Khushbu, sorry, Madurai, Roshna, Samra. Where is everyone?
I'm
Savi?
here, ma'am, but I need a bit orientation for how to do all this thing and how to start actually. So is there any session of yours that so that I can see that how to start all this stuff and what actually we are supposed to do?
How to start? I
For
didn't get
OSCE
your
preparation,
question, Annie.
for OSCE preparation, what actually we have to do and what we have to do.
She wants a bit orientation first.
Orientation.
Yes, ma'am. So is there any session of yours on the YouTube or something so that I can get orientation at what actually we are supposed to do?
Yeah.
Where we have
There
to
is
do?
Madam lecture of infertility or subfertility in last few months.
Yeah, there was subfertility session. No, there is, I think YouTube, we have previous sessions which we did for the exam orientation. Those sessions will be there. I will ask the
Yes, ma'am.
MedExam team that to just send you those. I think they are freely available on the YouTube, the orientation to the exam.
I need orientation, like
No problem.
just
We will help
to.
you with that. No worries. We'll help you with that. Shakila, are you there?
Yes, ma'am, but sorry, I'm in duty, so I can't because even I'm closing and attending my patient in between is coming. Otherwise, sure, this is very good case I should present.
Okay, okay, all right. Okay, you know, anybody can come up. There is,
And
it is
what
not,
is the usual timings of your discussion and all?
you see, we don't have regular timings. We are just doing random sessions, but of course, we inform in our group maybe a week before that, okay, this time will be our session. We were planning another activity, but unfortunately, I was caught up in something else. So we will be more, you know, regular with our sessions and with our activity in the group. Everything will be in the group and it will be informed to you at least 3-4 days for the activity.
This group only? This group, or is there any other group?
No, this group only. There is no other group. Same group, same things go to the Telegram group, same thing come in the WhatsApp group, okay?
I think I'm not there in Telegram group. Can you forward me the required link and orientation session so that I can start preparing for it?
Sure. We will do that.
Okay.
Our team will
Thank you.
contact you and they will help you with that. Okay, so please come on, girls. Somebody should come up. Roshna, can you take it? Samra? If none of you will come up, then of course I cannot do the task, right? What is this? Abda, can you come up? Aisha?
Assalamu alaikum. Is this a simulator? Should you be the simulator and I'll ask the question, or you will be the examiner?
No. You see, what is written here? It is a case-based discussion with the examiner. I can hear myself. Now it's okay. Can you hear me?
Yeah.
So this is a case-based discussion. So yeah, one thing again, very, very important. Once you are going for any OSCE exam, please read the scenario very carefully, okay? People are in that anxiety of exam, they don't read what is written on the paper. It's very important. It's like here, the first thing which is written is case-based discussion with the examiner. So if you are not paying attention to this word, what you will start with? You will start as a simulated patient task. Although it is not a simulated patient task, it's a case-based discussion. Okay? So reading the station properly is very, very important in the exam. Especially in the long case in RCPI, you don't have much information available with you. Okay? Few things will be written, but the main thing what is expected out of you in that station, that will be there. So read it carefully and then start the station. An OSCE station like RCOG, you don't have 2 minutes of reading time. Those 10 minutes there for you that you will first read your task, and then once you have read and you think, yes, now you can start. So you will say, I've read the task and I'm ready for the discussion. Okay, clear? Okay, so Abda, are you okay? We can start with you. Hello. Everybody disappeared, huh? Don't be shy, girls.
No, not disappeared, madam, but I'm not prepared for that.
It's okay, no problem. You heard, you were there in the session, right? Full session.
What is now do?
There is nothing. If you don't want to do it, it's fine with me. No problem. Okay, if nobody want to do it, then we can go to the mesh complications part of the day. Okay. Okay, anyways, let's just, nobody wants to do it. We will just do it as a discussion. Okay, who's there? No problem. Samra, everybody is on work. Yes, Sunita, come on. You can do it.
Rushna wants to do. She messaged you, yes.
Okay, she messaged. Okay. I'm waiting for somebody.
She just messaged. She just messaged.
Uh-huh. Okay, Roshna.
Hello, ma'am.
Yeah, you want to do it?
Yes, I will try.
Good, good, good. Very good. You see, it is just a free session. Please come up, open your, you have to speak. Unless you speak with us, how you will speak in the exam? The confidence will only come, even if you speak wrong, it doesn't matter. This is just a practice session. So please come up, don't feel shy. This hesitancy will only go once you start practicing, you start speaking, okay? You might be very knowledgeable, but if you don't speak that knowledge out, nobody knows. Examiner, they don't know you from before. They will only consider what you have told them. So please come up and try to do the task. These are free sessions and nobody is, penalizing you for giving a wrong answer or anything. So it's very important for you people to practice and, in front of people, it boosts your confidence, okay? You might not say everything is, whatever you are answering is correct, but still it will boost your confidence. Thank you so much. So yeah, now you read this task. I will put a 10 minutes timer, then I will ask you questions, okay?
Okay.
Okay, I've started your time. You read the task and then tell me once you are ready, okay? Remember,
Okay.
this is going from your time, huh?
Okay. Can I start?
Yes, sure.
Hello, I'm Roshna, one of the exam candidate. I have read the instructions and I'm ready for the structured discussion.
Okay, hello, Dr. Roshna. Can you summarize this case for me?
Yes, this is a patient, 55 years old, Mrs. Alexandra. She has a complaint of leaking while coughing, running and lifting loads for past 6 months. And she has tried some, she has tried pelvic floor exercises, but not working. So she's here for the management options.
Okay. So what part of history is important in this? What you want to know in her history?
First of all, before managing the patient, I would like to ask some history from the patient to know more about her and what investigations has been done. In history, I will ask her since when she is having this problem and whether it is associated with any other symptom like pain in the abdomen, any burning sensation in the while passing urine, and whether she has involuntary leakage while rushing to the toilet, or she has any leakage of urine while coughing or doing any heavy exercise or lifting heavy loads. And I will also ask about any bleeding while passing urine, and I will also ask her about her periods, or whether she has undergone a menopause, and whether she is sexually active, and whether these symptoms are affecting her quality of life. And I will also ask her about her cervical screening history, any contraception she has used in the past. And I would like to ask her any medical history like diabetes, hypertension, any chronic cough or asthma. And I will also inquire about her obstetrical history, whether she has any difficult deliveries in the past, and how many children she has. And along with that, I will also ask her her social habits, including whether she smokes, taking alcohol, or any drugs she is taking. Also, I will ask her about her BMI and her mental health. And besides this, I would also like to ask her drinking habits. This is all I will ask in the history.
Okay. So what initial investigation would you like to do?
Okay. Initial investigations, I will do urine analysis
Why you want to do urine analysis?
to rule out any urinary tract infection she is having.
Okay. Then?
And I will do some basic investigations like complete blood count
What
and
information
sugar.
we get from complete blood count in patient with incontinence?
To rule out any infection and her hemoglobin levels.
Okay. What else? How will you
And
confirm about this type of incontinence? What you will do for the examination of the patient?
yes, for the confirmation, I will do the examination of the patient, including journal examination and her pelvic and vaginal examination. So in journal examination, I will look the general appearance of the patient, whether she looks anemic, jaundice, or malnutrition. And for abdominal palpation, for abdominal examination, I will do her abdominal inspection, whether any mass is visible, any scars of previous surgeries, and I will do pelvic examination, including I will ask her to cuff to demonstrate any stress incontinency. And I will do if there is any prolapse, I will examine the prolapse and stage of the prolapse. And I will take swabs for any infection, and I will do vaginal examination, and I will also see the if there is any vaginal atrophy.
Okay. So what is the treatment of patient with stress incontinence?
Okay. For stress incontinency, if it is diagnosed as it is a clinical diagnosis, so I will advise her for the general lifestyle measures, including if she is smoking, I will ask her to quit smoking, and drinking habits. If she is using excessive fluids, she should cut down. If any coffee or tea is excessively she is taking, she should have to cut down. And if her BMI is increased, then loss of weight is advised. And and any constipation, it should be avoided. And after general measures, and also I will advise her for the pelvic floor muscle exercises, that should be supervised. 8 contractions 3 times a day for 3 months, I will advise her. So these are the general measures, and others, if it is not if there is no improvement, then I will go for the medical treatment, that is duloxetine, that will be offered to her twice a day.
Okay. And then this has failed, then what you will do?
Okay. If the conservative measures are failed, then I will give her the options for the surgery. But before that, I will discuss with the consultant, and I will involve the multidisciplinary team, and surgical methods will be advised to her after. But before doing surgery, we will advise her to do urodynamic testing to confirm the stress incontinency. In surgical procedures, we have a culposuspension that can be done either open procedure or a laparoscopic procedure, and there are other sling procedures are also there, transvaginal sling procedures, and
Okay. So what are the common side effects of surgical procedures?
common side effects of surgical procedures are like infection, pain, bleeding, and retention of urine,
Okay.
recurrence of the
patient is having-
symptoms.
Yeah. Okay.
And injury to nearby structures.
Okay.
And failed procedure.
Yes. Anything else? Okay, what are the common complications associated with mesh insertion?
Okay. The common complications associated with the mesh procedure are erosion of mesh, pain, bleeding, infections.
So what you do if you see if the patient is having any complication?
If she is having any complication, mesh complication, then we have to take the complete history from the patient and examine the patient whether it is whether mesh is exposed or if it is infected. Then accordingly we have to if it is an infected, then we will give antibiotics and estrogen treatment, so it will reepithelize or sometime excision of exposed procedure is done. And removal of mesh is a complicated procedure.
Your time finished? Okay, thank you so much. Actually, it was an excellent performance. Okay?
I don't know, ma'am.
No, really, it was an excellent performance. I would like to take opinion of other people who are here. Anybody want to comment? Yes,
Yes,
Shakira,
ma'am.
very good.
Yes, ma'am. Very good. She covered all of this, but only I think she did not ask that one, her weight, BMI ratio, but
No,
excellent
she
performance.
addressed BMI also. In the history, she addressed.
No,
Her
ma'am,
history-
very good. Very nice. I liked so much.
No, very nice. You were, so confident. You covered each and every part of the discussion we just had now. Maybe few things were not there, but you performed very well. Excellent. Okay.
History, I think many points I missed in the history.
No, there are just few points, not many points. Don't undermine yourself. You performed very nice and you passed the station for sure. Okay?
And thank you
course,
her for she came out for as a volunteer among us.
Yeah, first of all, thanks for coming up. And then you performed very well. Okay? So you covered each and everything, most of the things, maybe few things like in the treatment part, the conservative treatment part, you did not mention about the pessaries or the support, vaginal support. This is the only thing you missed. Then surgical part, of course, you were not very sure. A few things you mentioned. Have to brush yourself more in the surgical part, but the history part was excellent. You covered all the points in the history. Okay. Examination part was perfect. You covered everything. And the conservative part you did well, very well. Surgical part was, just borderline, not excellent. But yes, you performed very well. Thanks a lot for coming up and really doing this task. So you see, it's not difficult, girls. You just have to have the initial courage to come up and start speaking. You all have the knowledge because you are studying. Most of you have passed the exam and you are about to appear in the last part of this exam. So knowledge part is not an issue. Just that confidence and that courage to come up and speak, that is an issue that will only come. It will, it has to be from your side. Nobody can push you to do things. You all are adults. So yeah. So yeah, you performed well. Okay, I don't want to. Okay, let's go to this one, mesh complications. Okay, so mesh complication. Yeah, you see these are again from the guidelines. So first, if the patient is reporting you with any complication of the mesh, so in the history part, you have to check that was the mesh inserted recently or there is no history of mesh is documented. Sometimes it is not documented. People will do it but not document. Anyways, if the recent mesh that is less than 6 weeks since transvaginal mesh procedure, then you ask for the exact symptoms of the patient. So as we discussed earlier, what this pain in the groin and pelvic pain, this all will come with the mesh. So pain in the pelvis, lower back or thigh especially, it is a sign that the mesh is irritating the nerve and the pain is going into the thigh. Okay, so awareness of the mesh, like during intercourse, you are having pain or bleeding, or your partner is aware that there is something inside, or there is pricking pain in the vagina, there is any bleeding, or you can palpate the mesh, there is recurrent urinary or vaginal infection, or there are other symptoms of urinary tract like incontinence and voiding difficulty or retention is happening. So that means there is some problem with the mesh insertion. Okay, so if none of these symptoms are there, then of course reassurance is more than enough. Then they are talking about women who are experiencing pain in the pelvis, vagina, back, thigh, bladder, bowel infection, extrusion. These all you have to, we'll go to the next slide. Okay, so if these symptoms are there, so first of all, your documentation is very important, that you have to document each symptom which is expressed by the patient. You record that impact of that symptom on her quality of life. This word quality of life is very important in this exam. So please keep mentioning this word quality of life, relationship, social and occupational function. Of course, it's very important in our part of the world also, but there it's very, very important. So they expect you to, verbalize these words. So remember that these things, how it is affecting her quality of life, her personal relationship, her social and occupational function. So you have to take a complete gynae history, obstetric history, and all potential other causes of this problem. Then mesh operative history, was initial procedure, was it an initial procedure or there was any other procedure done before that, when it was performed, where it was performed, and did she receive any treatment before for this complication? How is her mental health? And if possible, try to get a record of the surgery. Okay, then clinical assessment, of course, it is your abdominal, pelvic and vaginal examination, and signs of mesh complication on the examination will be tendered on touch. You can see the mesh in the vagina once you put a speculum inside. There can be vaginal adhesions or scarring in the vagina, and then you have to, if required, you have to do some investigation, other investigation which can be a cause of the symptoms of the women. If you don't see all these, if you don't see a mesh, if you don't see any erosion there, then there can be any other cause of the complications or the symptoms patient is presenting to you. Okay, so if you are suspecting a mesh complication, then of course you have to refer the patient to the specialist where she did the procedure, or to a multidisciplinary clinical service who specializes with the patients who have complications, who are inserting the mesh, and who are competent to deal with the complications with the mesh. Okay, and women who are with uncomplicated mesh erosion exposure, you can treat them yourself. Either you have to remove the mesh, or you have to revise the mesh. You have to remove and reinsert. Okay, clear? Hello.
Ma'am, I have one question. In the investigation for stress urinary incontinence, we should offer the patient for ultrasound also to rule out any pelvic mass?
No. You see, ultrasound, which that is an additional test. One, you have to check the post-void urine with the ultrasound. That is just to check if there is any, extra amount of urine remaining after voiding. That is post-void residual volume. You have to check that with the scan. Okay, that is one thing. And then if you are expecting a fibroid uterus, suppose, or any pelvic mass or any abdominal mass, then of course you have to go for an ultrasound. Okay, but it is not mandatory investigation.
Okay, so we will be not tell to the examiner that in the investigation we will do the urine dipstick and ultrasound to see any residual volume, urinary residual
You will say
volume.
this one. You will say that you will do a urine analysis and you will do a scan to check any post-void residual volume of the urine. And then if you are suspecting any problem in pelvis like a mass or abdominal mass or a pelvic mass, then of course you will perform a departmental ultrasound to rule out any masses.
Thank you so much, ma'am.
Welcome, no problem. It is just if you explain everything, then there is no problem. What investigation, Sunita? This is what I told you, in stress incontinence, of course, the history part is the most important. The examination part is, of course, you do a cough test, and if you have to rule out any prolapse. In the examination part, an investigation is the same as we discussed earlier, that is urine analysis, the basic test. And then if you see infection, you go for a urine culture also. And then you do a post-void urine to check the residual volume of the urine, and then if you are suspecting any masses, you go for ultrasound. And then if you feel the case is complicated, then next level is the urodynamic study. Okay, got it, Sunita? Yeah, okay. All right, I think that is all for the session. And hopefully we will do more sessions next 10 days or 2 weeks. And please try to put up your queries in the group. I will inshallah be available to answer all your questions. And for the sessions part, try to come up, and once I'm requesting you people to start participating or taking the task, it is for your benefit, okay? It will just boost your confidence. Anything else you people want to know?
Excuse me, Dr. Uzma.
Dr.
Uzma, will we ask for RBS, random blood sugar, in investigation?
Investigation, if you're suspecting, once you are talking about history taking and medical history, so you will just say that, of course, I want to exclude diabetes in the patient. That is why if she is not diabetic or if the patient is obese, then you will mention that I would like to know her diabetic status, or if she hasn't done any investigation, I want to know her blood sugar levels in the form of HbA1c or random blood sugar. If random blood sugar is coming high, of course, you go for the HbA1c, and then you refer the patient to endocrinologist.
And Dr. Uzma, we will ask BMA from the examiner, or if we have a long case, or from patient.
Yeah. That's what, in the long case, if this case is coming as a long case and BMI is not mentioned, that is part of your history taking. So of course you want to know her BMI, you will ask whatever. You see, they will not tell you anything which you are not asking. Like in my exam, there was this postmenopausal bleeding, old lady. Yes, Samra, sure, we will give you the topic early, 1 week time we'll give you. Okay, sorry. So for the long case, nothing was mentioned, only the age was mentioned, and patient came with postmenopausal bleeding. So no investigation done, not done, report, nothing was there. So once I asked them that, did you do any ultrasound? Did you do any investigation? Then she, from her under the table, she was holding an ultrasound report. Then she gave me, this is my scan, which I did. So it was very, I think, 20 millimeter endometrial thickness. Then I asked that any other investigation performed, like then the examiner was sitting behind the patient. She said, what investigation you want to know? Said, any hysteroscopy performed? She said, yes, hysteroscopy performed. Biopsy report is there? Yes, biopsy report is there. So they want you to ask for the investigation or ask for any particular thing. You want to know the BMI? You ask, I want to know, do you have any idea for your height to weight ratio? So if either the patient will tell you, or if it's not mentioned, then the examiner will tell you. Okay.
Dr. Uzma, in both long cases, either gynae or OBS, like in FCPS, we ask for the baseline investigation for every patient. In MRCPI, there is a specific basic investigation. Can we ask?
You see, whatever you will say in the exam, they want you to justify this thing. Like she said CBC, right? So CBC is not that relevant in incontinence, is it? If you are suspecting infection, you do a urine analysis. If the patient is coming with fever, then of course CBC, you can say that you want to know if WBCs are high, then you might go for a CRP also. But just speak only of the investigations that you can justify, which are relevant to the case.
Means we can ask in special baseline investigation, like we in FCPS, we ask for every patient, either gynae or OBS, CBC, RBS, complete urine examination, blood group, etc. In FCPS, we ask
No, in
for
RCPI, yeah. FCPS, you can ask, but I think in any exam, if you're doing a RCOG or RCPI or any FCPS exam, whatever you are saying or asking from the patient, you should have a rationale behind it, no? Why you want to do any particular test? Not just because you want to tick the box. You want to get some information from that investigation, right? So you can do as many investigations as you want, but you have to justify whatever you are offering to the patient.
Okay, thank you.
Especially in an RCPI exam. If the examiner is from Ireland, they are very particular. They will say, okay, so why you want to do this? What information it will give you? What benefit it will be for the patient? So you just want to waste the money, you know?
Yes.
So whatever you are saying, just you should be able to justify that word.
Okay. Thank you.
All right. Okay, so I think that is all for the day. Thank you very much for attending the session and being proactive in the session. I really appreciate your presence. Hopefully see you soon, inshallah, in another session. Okay. Thank you. Take care and goodbye.